afternoon. Today we are excited. We have our two of our newest additions to the Reid Health physician staff. They will both be at the Reid Comprehensive Bone and Joint Center. They just changed names, so I have to remember. And we have Dr. Ted Kostiuk, and he will be one of our new spine surgeons, and Joseph Williamson, who will be a pain management doctor.
Okay.
Then, hello, can you hear? Mm-hmm. Okay. And they both are going to speak and be able to answer your questions. So without further ado.
Hey, I'm Dr. Ted Kostiuk. I'm an orthopedic spine surgeon. Just started over with Reid Health. I have about 6.5 years experience practicing in Southwest Michigan. Oh, sorry. Is that better? Okay. Sorry about that. I specialize in more of a minimally invasive type surgical procedures. That means that I do the best I can to make sure that you have the smallest incision and the smallest surgery needed to treat your problem or your pathology. I treat everyone like I would treat myself or my family. So when I look at your imaging and I talk to you about where you're having pain, and I look at those things together and try to come up with a specific plan to treat your problem. So not everyone gets the same surgery or has the same problem. And of course, we do that surgery as the last option. Before you get to surgery, there's a whole slew or range of treatments that we would do before that. I also joined Dr. Han Vien. He's the other spine surgeon with Reid, and we have a very similar philosophy, so you can be assured that you'll get a great treatment no matter which one of us that you're going to come see.
Good afternoon. My name is Dr. Joseph Williamson. I work alongside Dr. Usmani, who's the current pain provider at Reid. And the best way to kind of understand what is it that I do and what he does is by thinking of it as interventional spine procedures. So we are labeled as pain management, but our interventions is really what we do. So for example, people with neck pain or low back pain, those are kind of the main conditions that we see, and we'll see you, we'll evaluate you, we'll figure out what's going on and what interventions we can offer you, what injections, to be simpler, we can offer you. And if it's something we can do to keep you away from surgery or to help the surgeons, that's kind of how our thinking is. And we work very closely with both Dr. Han and Dr. Kostiuk. They're kind of like their right hand men. And sometimes we have to do injections in your back or your neck to help them figure out what the problem is or where to operate or where not to operate. And for us, as well as interventions, we like to help people get back to their quality of life, and functioning is key. And so if you're on pain medications, patients come to us and they say, I don't want to take my pain meds anymore. Is there anything else we can do? And that's kind of where we come in. And we can do an epidural or injection in your neck or your back. And if that gives you any kind of relief, that could help your primary care provider or whoever else is prescribing you the medication to maybe get you off of that or wean off of that or to at least take less of that. And the interventions are, very minimally invasive. It's a needle, and, we'll go through all the risks and benefits, but if that can get you off of, pain medications, and if you need a few of those a year just to keep, your quality of life and functioning at bay, then, it could be a good alternative for you. Questions or?
Mm-hmm.
When you asked about when you say minimally invasive, can you give us some examples what that means?
You can start with yours.
Sure. So everything that I do is through a needle. And so if you come in with neck pain or if you come in with low back pain, there are procedures, let's say for arthritis, and where we can, go in and actually burn the nerve. And that can give people, 6 months to a year. It's called an ablation. It's something where, as degeneration or breakdown of your bone happens and the grinding can cause, people with some low back pain, and that's all done through needles. And the same thing with the neck as well. Epidurals or the ablations, like I talked about, are done through needles. So I don't make any incisions, and I'm pretty sure Dr. Usmani doesn't make any incisions. We leave that up to the the surgeons to do the cutting and all that. So,
Can you explain, I'll probably pronounce it wrong, ablation, is that what you're saying?
yes, ma'am.
Explain what that is.
Sure. So, patients who come in, let's say you don't have any kind of pain shooting down your legs, but you're like, oh, it hurts across my back, hurts somewhere down here. Okay, so we'll get an x-ray, maybe we'll get an MRI or a CT scan if you can have that, and we'll take a look and see, there you have these kind of joints of your spine, and as we all get older or just, your profession's degeneration or breakdown happens, and so that can cause people this low back pain. So what we can do is actually go in through needles and a 10-minute procedure, go in and block the nerves that could possibly be causing you this pain. So what happens is you come off the table and someone will call you the next day, and if you receive temporary relief in your back, and you'll know, you'll stand up, you'll walk around, you'll go home. If you feel better around 80% for like the rest of the day, let's say, then hey, that was a successful block. We'll do that again in a couple of weeks, round 2. Same thing, but we'll use a different medication. If you get 80% that time, then hey, we have 2 different times, 2 different medicines of successful relief. Then we can go in and use the burning kind of ablation technique where we're deadening the nerve, the signal that goes from your back to your brain. We're kind of shutting it down for a while. And what that does is gives people 6 months, I've seen a year, maybe 2 of relief. Now, the way God has created us, the nerves do grow back. How fast it grows back is just dependent on each person. But it is a procedure you can have again. It depends. If you have pain on both sides, then yeah. If you have pain on the left side, then maybe we'll just block the left side. And if they don't work at all, then we just kind of keep going and taking a look and see. There's other joints down there. Could be your hip, could be your SI joint. When people come in with just back pain, I mean, there's not really like a single, oh, that's 100%, that's what it is sometimes. A lot of times it can be unclear. So if we do an injection that doesn't help, we just kind of go down the line to figure out what it is. And if they don't help and there's an indication for surgery, then that's where...
How many can you have a year?
You can have a repeat ablation every 6 months at the earliest if you need it. But you had to have had successful relief for that time. It can't be like, I had 2 weeks worth of relief and I wanted to get it again. It has to be pretty significant relief for at least 6 months to repeat it.
I went through this with Dr. Chowdhury and had the 3 different procedures. Can you hear me?
Yes, ma'am.
Okay, the 3 different procedures, and it did help. Now, should I come back because it's starting to hurt again?
Yeah, sure. I mean, if you've had an ablation before and you're starting to feel your back pain come back, there's definitely a reason to come back because it's not 100% guaranteed that that's what's causing your pain again. Now, through an evaluation, we can figure it out whether or not that is the same pain you felt before. Is it worth repeating it? And once you've had an ablation, you don't have to repeat the blocks again. Does that make sense? So if you get through the 2 blocks and then you have the burning procedure, right? You're pretty good pain relief for 6 months or a year, and you want to get it again in a year because the pain's coming back, we can go straight to the ablation. You don't have to do the blocks again.
I had that done on the 28th of June.
Okay.
But my back doesn't have that excruciating pain like I had, but it made my legs feel like they weigh a ton when I walk. Wobbling like a gun.
Yeah, I mean, that could definitely be something else going on in your back, especially if you're having problems in the legs. It's very, it's not really likely to have come from your arthritis, but indirectly it could be pinching on a nerve or your spinal cord became compressed, which, that'd probably warrant a evaluation.
So you are taking new patients?
Yes, ma'am.
Where are you?
We're at the Ortho and Spine Clinic. What's the address? 1400?
Howard Highland?
1400 Highland.
Do you ever insert anything in between your discs?
No, ma'am. I don't.
You don't?
No, ma'am.
You do? How many do you insert?
We can talk.
Talk loud.
We can talk about that. So someone had asked what minimally invasive meant. The first thing we want to do is make sure that we're treating the correct part of your back that's causing the problem. That's where Dr. Williamson comes in. Is occasionally, or not occasionally, but half the time someone comes in and they have a lot of arthritis in their back, we have a lot of joints in our back. So when we look at all those joints and all those nerves, it's our job to figure out what's the pain generator. Where is your back pain or your leg pain or your neck pain or your arm pain coming from? Because then we can specifically treat it with therapy or with an injection. And then if those things don't work, that's where I come in. So when I say that I want to be as less invasive as possible, that means that I want to focus on the problem itself and not treat more than we need to, because surgery in and of itself, other than fixing your spine, it's also very traumatic on your body. And I want to make sure that when I do use that knife that Dr. Williamson doesn't use, is that I'm making my incision as small as possible, but as big as I need to make it, and that I'm not going to damage your soft tissue, because that's the part that's painful most of the time after surgery. In the past years, in the 90s and early 2000s, we used to do a lot larger surgeries to accomplish the same goals that we can accomplish now through a lot smaller incisions, because we have tools now that are also smaller and more precise. We use things like microscopes, and we also use a robot at Reid Hospital to help us specifically put our instruments where they need to go, to help us put screws in your spine where they need to be very precisely. Where we used to do those things wide open, where I'd have to see all of your spine to be able to place it in the right spot, I can now plan for that surgery using the robot and place those instruments very precisely. So that causes a lot less pain after the surgery. You're able to go home faster, and occasionally even the same day. Does that answer your question?
No, I mean, yeah.
Okay. So as far as the spacers go,
According to my x-ray, I have no cartilage in between any of my discs.
Okay.
From my neck on down. And I'm shrinking. I used to be 5'8", I'm 5'6.5" now.
Yep, and that's very common. Once all of us pass the age about 30 or 35, our discs start to get less tall. That has to do just with age. Our bodies start to degenerate, and the disc tissue itself gets less supportive. So just our own body weight helps push those discs smaller and smaller as we get older. And some of that's based on your genetics, and some of that's also based on the type of work that you did or still do, by your posture, by your muscle strength. Those things can all influence that disc height. And we have a disc between each one of our bones in our back. So if all those discs fall down, you're going to lose 1, 2, 3 inches in height as you get older. So we do see that. We can't put a spacer between every bone. We could. That would be a lot of surgery. I don't recommend that. But we do the least amount possible to give you the best outcome.
My daughter had that surgery, but she kept getting shots on each side of her back, and the doctor said it was time. And she had something put in between her 4th and 5th vertebrae. She had to lay, after surgery, she had to lay flat on her back for 6 weeks. She said she wished she had done it early, because she gets along pretty good now. And my daughter's 50, so see, it does work.
So laying, I can't speak to that surgery, because I'm not sure exactly what she had done. It's very common for us to operate on that level in our low backs at L4 or 5. When I plan for my surgeries and the types of surgeries and the outcomes afterwards, my goal is always to get you up and get you walking right away the same day of the surgery if we can. Every once in a while with the spine surgery, you can have something called a spinal fluid leak, which you may have heard of in the past. That would be the only reason why I'd keep you flat in bed, but typically it's only for a day. It's not more than that typically. So I can't speak to the 6 months. There may have been other complications, but hopefully she's doing okay now. So.
Is there any rehab after you have that procedure?
There can be. I specifically will order it if needed for that patient's problem. I said there can be rehab after surgery, but not always. Specifically, I do rehab on someone's arms or legs if they have weakness, and that weakness can come from nerve compression. So so just to backtrack for a sec, the main things that I treat with surgery are arm pain and leg pain, or those types of things. So numbness, tingling, weakness, pain in the arms and the legs. Back pain is kind of a secondary thing, and I can't always treat that. And that's what surgeons should tell you, is that we can treat back pain somewhat with back and neck surgery, but really the main thing that we treat are the symptoms from the nerves. So your back pain should improve, but it may not all go away. So That's the unfortunate outcome of all the joints and discs that are in her back, is I can't fix each one of them. Not yet.
Is there an age limit when you won't do anything?
What's that?
Is there an age limit when you decide not to do anything for a person?
Not necessarily. I take all the factors into consideration, and we make a choice together.
My husband is 70, and he has a very bad back. He was told the curvature in his upper back is, I don't remember if you say 80 degrees or 80%. And he was told if he was a young person, they would straighten it out with a rod. But at his age, it is too grueling a surgery, and the recovery is also grueling. So he is left with nothing. Is there anything that he could do? Could he get any help? Because he has a lot of back pain due to that curvature.
Sure. So it all depends on what he's had before. So as far as treatments go, is that an option to see Dr. Williamson could also help him control his pain. I can't speak to the surgical options without seeing him in my office and getting X-rays or looking at his previous X-rays. But sometimes with really big curvatures in our spines, the surgery to correct those the surgery can be very large. And as I said before, surgery in and of itself is traumatic to your body. So depending on your medical comorbidities or the other problems that you have, just from age, it may make that surgery too traumatic for us to say that we should try that. But every patient's different. So like I said, I take all of those things into consideration when we have a conversation about it. Yes, ma'am.
Dr. Williamson, how do you treat sciatica? Is there anything that you can do to get rid of it?
Sure. So the question was, is there anything to do to treat sciatica? Yeah, so sciatica is kind of a general term of, pain going down my leg. And the question is, why is it doing that and what's causing that? Now, if it's one leg, it's more likely maybe something coming from your back, and that's what an evaluation would do. X-rays, MRIs, to help us to see if you have a pinched nerve in your back causing that, shooting pain down your leg. And yes, depending on, the MRI, we would probably recommend an epidural, which is a steroid injection. So putting steroid around that inflamed nerve root is kind of what the goal is, to calm that pain down your leg. Now, how many you can get really depends on how much relief you get. If you get, 80% relief for a week, we might consider doing another one, but the limit is really 3 within 6 months or 1 every 3 months if you need it. Now, if you get, significant relief, but it's only a couple days worth, and you have a really bad disc herniation, that's kind of where we have to make a decision together if the injection helped you, but not as long as you'd like, maybe it might be worth sending you to talk to one of our surgeons then for further assessment. Did that answer your question?
Yes. But now, I also have a prosthetic leg.
Mm-hmm.
But I had sciatica before I had the...
Sure.
So in my mind, I don't think that's what caused it. Having a prosthetic leg.
Sure, and things can change. Obviously, if you get a prosthetic, then your gait could change, and balance out your pelvis and how you walk. And our goal basically is to rule out that it's coming from your spine, right? So if we do our tests and do everything, and we do injections, and we say, you know what, we've done everything we could, we've done our test, and we don't think it's coming from your back, well, then at least you can kind of figure out, okay, maybe the pain in my leg is coming from my hip, or maybe it's my diabetes affecting my nerves, or something else going on. So that's the goal of our spine care. That's really the ultimate goal, is to make sure it's not coming from your back, and if it is, to take the next measures to help you. So.
Can you go through the pain management series and then also go to therapy?
Sure. Can you elaborate more on what you mean by series?
Pardon me?
Could you make that more clear about what do you mean by series?
The in pain management, the first, second, and then the third injections in your back.
Uh-huh. So you want to know...
What was the last surgery or the last injection you were talking about?
That you
put like right here.
The epidurals?
Yes.
Okay.
Yeah.
Yes.
Can you do therapy and go?
Oh,
through-
I understand. Yes.
Yeah.
Yes.
Or should you-
Absolutely. No, that's a great question. So that's something we would discuss together. Now, where it gets a little difficult is sometimes your insurance will require you to go 6 weeks of physical therapy before they'll even approve us getting an MRI of your back. Or some insurances require you to go to therapy before they'll approve the injection. Now, if you have an insurance that does it, and we get an MRI and, we recommend an injection, then obviously if it's so bad that you can't tolerate therapy or ambulate or walk, then I would definitely recommend doing an injection, see you back in 2 weeks, see how you're doing. If you're getting better, then maybe slowly, gradually get you in therapy. Sometimes people need the injection just to get through therapy. You see? I mean, your goal is to get into therapy, giving your full effort and doing the exercises, but if you're in pain, how are you going to be able to do that, right? And I will say just about your husband, the scoliosis pain is actually very difficult. I'll just be honest. There really are very few, if any, interventions for scoliosis type pain. Now, if it's specifically like his low back or his neck, we might have something to work with there. But thoracic pain is one of those black boxes for us in the interventional world. That scoliosis is a tough disease to live with. And ultimately, a lot of our patients we do see, having to talk to their primaries about, ultimate medication management if they're too old, or not safe to progress with surgery or, so I just want to make that clear, so.
I got a question. This is the last one, I promise you guys. If I switched over to either one of you guys and you guys did a procedure on me, am I going to see you every time I come or am I going to see somebody else?
That's a good question. For my clinic, as I know, I would definitely be the one to see you.
For my clinic, I have to say that it depends. Usually it's going to be me, but if you were to have surgery with me, the follow-up appointments may occasionally be with one of our physician assistants or our extenders or mid-levels we call them. Yeah.
If you're going to work on me, I want you to follow me all the way.
And it doesn't mean I'm not following you. If they see you, is that we communicate all the time. But we work together in clinic at the same time. So I'm still there the same day. If you were to see one of my assistants, I'm still available in there seeing other patients. We just get through it so we see everyone in the same day. It allows us to see more people if we each see people. But I'm still approving all the things that the mid-levels do.
And you won't be doing that virtual, calling me up and say we're going to do it over the phone.
Now that's a possibility. I'm not saying that we're going to have to do that, but if someone requested that, yes, we could. So. Yes, ma'am.
Ablation, you go through 3 steps. That first one, I don't know if I'm going to answer your question.
I don't know, but it's the same thing.
When they give you that first shot, and they want to know what percentage did it make you feel better if you say, it was okay, then your insurance company's not going to pay for you to go through the other 2 steps.
Right.
So you should always say, oh yeah, it worked fine.
Yeah, that's the recommendation, not even question, was to say you feel better after the first one. Now, I will say this, there is some truth to that for sure, that, we definitely are looking for 80%, truthfully, right? Because if you don't, and there's 2 ways, I mean, if you really genuinely don't have 80%, that may not be the pain generator. It's a test, right? And the pain relief is not supposed to last for 5 days. It's a temporary numbing medicine that we are blocking the nerves that innervate or that are giving the feeling of pain from the joint, right? So it's a very specific test that if you have 80%, then that's probably the target. If it's not, then we go back to the drawing board, figure out where is your pain truly coming from. And yes, 80% is the magic number. I mean, 80% first time, 80% the second time, then we can send it to insurance of, hey, we would like to recommend proceeding with the ablation. But if it's less than that, we definitely would not want to go to the next one.
I always tell a friend of mine, she's sitting over there, she gets injections from time to time. And I say, the doctor didn't tell you to dig a ditch and climb a tree, but either the same day you got the injection. I said, you wanted you to be quiet for a while so the medication can go through your system. So am I on the right track or not?
Yeah, basically, the key is, you know, for it to be very clear, what we do is we look at 1 or 2 at most maneuvers, right? Meaning before the procedure, if bending forward or bending backward and twisting causes you pain, then that is what we look at after. It's not that, oh, I was not able to walk through Walmart with no pain. No, it's before the procedure, I was able to lean back, turn, and twist, right? Ooh, this hurts. Ooh, that's a 9 out of 10. After we do the block, someone will call you or check in with you next day. Hey, you know what? When I went home, I was able to lean back and twist with less pain. That's the test. It's not like, you know, you're able to climb trees. And that's right. No. Good question.
And just to clarify on that is that what we're trying to get to is that we want to know what's causing your pain. So it may be that those injections treated some of your pain, but there may be something else that's also contributing to it. So our job is to figure out what's causing your pain and help you get back to what you want to do. So it may not be that you don't want to say 80% because we want to help you figure out what else could be causing the pain. So we have lots of things that can cause pain. It can be joints, it can be muscles, it can be ligaments, it can be previous injuries that caused damage to our nerves and now we just have chronic pain. It can be diabetes, it can be our brain causing the pain. So there's lots of ways that we can figure out what's causing it and why. So I guess what I'm trying to say is we want you to be honest with us, so that we can get to the bottom of what's causing it and help you get back to those things you want to do.
Mm-hmm.
Do you guys do self-refer or does PCP have to refer to your practice?
You can self-refer, but that's based on their type of insurance, I believe, is the answer I usually give. So I would always check with your insurance provider or ask your PCP. They may know. In addition to that, you can always call our office and we can help you figure that out as well.
Mm-hmm.
Yeah, if you ask for me, I'm the practice manager, Emily, and if you have a question regarding like if your insurance will cover a certain procedure or a certain type of office visit, or if you just want to find out if you can do a self-referral, you can always call and find out. We can facilitate that for you and get you an appointment based on what type of insurance you have, and we'll let you know at that time if you need a referral from your primary care provider or not.
Did everybody hear that? Emily. Emily can help you.
The microphone snuck over while I was chit-chatting. Was everybody able to hear me? No. I'm Emily. I'm the practice manager for Reid Comprehensive Bone and Joint Center. If you ever have a question regarding insurance, if they would cover a certain type of office visit or procedure, you can call the office and ask. Any one of our front office staff or myself can help answer those questions for you. If you have to have a referral from primary care, or if you can do a self-referral and just go ahead and make that appointment, we'll be able to answer that question for you. Some types of insurance, especially if you have like a commercial Medicare, a lot of times they'll want you to have a referral from your primary care physician prior to making the office visit.
And just from my standpoint, and I'm pretty sure Dr. Usmani's standpoint, as far as the referrals goes, you know, the benefit of having a PCP referral from our standpoint is that we have somebody who's in the loop with what's going on with you, right? So for example, if you come in with low back pain and in both your legs, for example, okay, and you see one of us and we do our workup and we figure out, hey, you know what, it's not coming from your back. We got all the scans, x-rays, whatever it is. There's no interventions we can do. We've ruled out that your pain is coming from your back. Now we'd send you back to your primary doctor because now they probably need to look at some other tests to figure out there's a lot of things that can cause you with leg pain, but in both legs. And it's not necessarily coming from your back. Could be your blood vessels, could be your diabetes control, and you just don't want to see us and then not anybody follow up on that, right? So we'd communicate with them, hey, we've evaluated their spine, it's not coming from that, would recommend, looking at vascular, your blood vessels, or, medication, could be medication side effect too. We've seen that too. And you just want to have somebody in the loop who's following you. So that's the benefit, I'd say.
There's a commercial on TV. It's got about the Good Feet store, and it shows where the people have back pain, and then they get these inserts in their shoes, and then their back pain gets better.
That's a very good question. I'll give you my own personal experience. Is that my job requires me to stand all day to do surgery in the operating room. If I were to wear these dress shoes and try and stand all day in the operating room, my knees would be sore and my back would be sore. So I changed my shoes to have good arch support, and most of my pain went away. That doesn't mean I'm not going to have pain from time to time because I'm still standing in one spot for hours on end. But the short answer to your question is yes, is that your footwear can determine how much pain you have in your feet, your knees, your back, even your shoulders because of the way it makes you stand. That can create neck pain, it can cause headaches. So it's important to have the right support, and there's lots of different types of shoes. So I would make sure that if you're gonna go, don't just go buy a pair of shoes. If you're having pain and you wanna know if that's what's causing it, going and have someone look at your feet and help you determine what type of footwear would best benefit your needs.
And we have podiatry.
Right, and
So.
yes, that's a good thing. And we do have podiatry at the Comprehensive Bone and Joint Center that can help figure out what those problems are, because it could be arthritis causing your pain in your feet, and that's where they would come in.
What about a chair? What's the best chair to sit in?
That's
I
I was going to say.
You want? Yeah. No, go ahead. Yeah.
That's a really good question, and you know who the expert in that is the physical therapist. So they are the ones. The reason we send you to therapy is not only to help you with your mobility. At least I'm, assuming Dr. Kostiuk's the same. I'm pretty sure we actually went to the same med school, so we have kind of the same thinking. But they're the ones that can help you with ergonomics, fancy term for the way you sit, the chair you sit in, where to put your mouse, or the height of your keyboard, or when you garden, how should I sit when I garden on my stool? All these logistical questions. How do I transfer out of my bed safely? How do I sit on the toilet? These are one of the main reasons we send you there too. It's not just to, help you with your low back and pain, but it's also to help you with your thinking and approaching and making lifestyle modifications or changes of how to live safely.
I have a question. Normally, especially when we do Reid beside you, we ask, how did you come to Reid? Can you tell us where you went to school, what you've been doing, and how you came to Reid?
Sure. So I did all my training. I'm originally from Chicagoland, and I did my med school there and college, and I did a year of intern year in general surgery there. And then I did my residency at IU in Indiana here in physical medicine and rehab. And then I did my fellowship in interventional pain and spine at the University of Kentucky. And then we moved to South Carolina for 2 years, where I worked in private practice alongside neurosurgeons who did spine surgery, and I was their injectionist, if you will. And, God had a different plan for us, and so we're back here in the Midwest, happy to be here. And that's kind of how I got a hold of Reid through, I think I really just saw it on a job fair and, really just looked into it, and, wonderful, wonderful place. Definitely feel blessed to be here, so.
Dr. Williamson and I have similar stories. I also am born and raised in the Chicago area. I did my undergraduate school at Illinois Wesleyan. It's in Central Illinois, and that's where I met my wife in college. And through visiting her hometown, which is in northern Illinois, I became to believe that I wanted to practice in a smaller town. And didn't want to raise my family in the big city, and just like the feel and the people that were in smaller towns. So I went to medical school in Chicago at the Chicago College of Osteopathic Medicine, again, the same place that Dr. Williamson did. I did my residency in the same school, but throughout the Chicagoland area at 9 different hospitals, and then did my fellowship in spine surgery over at Ortho Indy for a year afterwards. And then I moved to Southwest Michigan because I decided I wanted to stay close to Chicago, but still be in a small town. Those towns over there were too small, though, for someone like me who's a subspecialist to grow a large, robust practice. So I started to look at other places to come that fit that checklist of having a small town that was also a great place to live. And I had other friends who knew about Reid, and some of the doctors in Indy who I knew or know still suggested that I look at Reid, and it's been a great experience so far, and I'm very happy that I ended up here. Any other questions?
Thank you. I also want to introduce two other people on your team. There's Emily from Comprehensive Bone and Joint Center, as well as Sierra. We'll put you on the spot. And Sierra is for lack of a better, she's the physician liaison. So I'm going to have to let her share what she does.
Can everybody hear me? I have a loud voice.
Just make sure.
Okay. Hi, I'm Sierra. So my title is the Physician and APP Liaison. So my department is Business Development. So when we have these new guys join, I'm the one that helps facilitate getting them in front of different groups, introducing them to other providers, helping build up their business, but also help making the community aware that they're here and the services that they can provide. Questions?
They're taking new clients. Taking
Yes.
new clients. Sierra knows a little too much about Medical Monday because we used to be in the State Department. So we want to thank you both for joining us today.